I'm a USF neurosurgeon practicing at Tampa General. I teach for Arthrex. So there seems to be an exponential growth in endoscopic spine surgery, in research and commercial interest, and these societies, as well as different parts of the world. Especially in Asia, where these surgeons adopted these techniques so much quicker than that we have. So it was my natural calling, and it was in my DNA to pick up these techniques so that I can fit in. So whether you're a neurosurgeon or a orthopedic surgeon, you have some experience in endoscopy, right? So for us neurosurgeons, we're used to doing ventriculoscopy versus orthopedic surgeons using shoulder and knee scopes. Key difference here is that with ETVs or ventriculoscopes, there's a working channel through which you can introduce your instruments through the scopes, whereas arthroscopes, you're making another incision to do these techniques. So maybe, if there was any delay in us adopting the scope into the spine, I think that's because there's really no dead space in spine, unlike ventricles or the joint capsules. So there's two different styles of endoscopic spine surgeries, kind of in a similar fashion. A single portal means you're using a scope and you have a working channel through which you're going to working doing your decompression. You can do neurodissections, you can cauterize. And biportal techniques you're basically making two different incisions and utilizing tools that are different, more normal to what you may be used to, Midas drill and Kerrison, for example. To discuss the pros and cons of two different techniques, I think it's another talk of itself. But myself, by training, I'm a single portal endoscopic surgeon, and that's what I'll focus on. When it comes to endoscopic spine surgery, there's two main approaches. First is interlaminar approach that everyone here is familiar with. Whether you're a McCullough retractor surgeon or a Matrix tube surgeon, you will be doing this left side interlaminar approach. What's advantageous about single portal endoscopic spine surgery is that you have access to that transforaminal angle. So typically when I do this technique, my incision is about anywhere between 10 to 14 centimeters away from the midline. So how I do this is by utilizing the Cambian's triangle outlined in red, so that I can dock my retractor safely there and my scope to start doing discectomies or foraminotomies. Here's an example of a patient that I treated earlier this year. So this is a 20-year-old female who came in initially on the right. Initially she came in with this MRI. So at the time she only had back pain and leg pains, and I scheduled her for surgery, and she got lost to follow up because she lost insurance. And she came back with this MRI 2 months later with complete foot drops now and increasing pain. So surgeons in this room kind of think about how you're going to treat this with that endoscope, right? So would you do a complete fascectomy, laminectomy? Would you do a fusion or disc arthroplasty? In my hands, with my tools, I performed a transforaminal discectomy. So this is how I perform these. So basically, I outlined a Cambian's triangle, both on AP and lateral here. And I marked that lines on the skin because I want those instruments, when I'm docked in the foramen, to look just like that X-ray. So once I dock my endoscope, I see I'm at the foramen. I do a foraminotomy with the drill. And once I did a foraminotomy, I can see the disc herniation pushing up the neural elements dorsally from the ventral side. And as I'm delivering the ruptured disc fragments, I could see these nerves coming down, and the X-ray is here to show that I'm able to reach midline and see how right at the level of PLL. The lady next day, foot drop completely resolved, and was quite happy. I don't have the post-op MRI for that same patient, but I put this in to show what the post-op MRI of transforaminal discectomy looks like. So this is a 43-year-old female that I treated who came in with just radicular symptoms, had a 4 or 5 caudally migrating disc fragments, ruptured disc. I did a transforaminal approach there. You can see resolution of the disc, and you see how there is really no scarring whatsoever. When I looked at this axial scan, I rolled up and down to find some scar tissues on the sides, and it was virtually absent. You can use the same transforaminal angle to perform thoracic discectomy, which I think is where it shines the most. This is a 60-year-old patient who presented with thoracic myelopathy, T8-9 herniated disc that was calcified. So in this case, I decided to use navigation because he was morbidly obese, and if you look at ribs, and that's the angle that I have to come into to get into the foramen. So to write between the ribs, sometimes it can be very challenging on the fluoro, so I use a navigation. So here you see the facets, so lateral facet. So I did a lateral fascectomy and foraminotomy, and the bottom here is a partially calcified disc. And as I do a ventral discectomy, I saw the thecal sac descend ventrally. So the patient initially presented with 3 out of 5 bilaterally in the legs, and I saw him just last week. He's 5 out of 5, despite that he still has some pain. So using interlaminar approach, now more of a midline incision. This is a 40-year-old male who is athletic, who came in with monoradiculopathy. He did not want any kind of big surgeries, so I performed a cervical foraminotomy. You can see the axilla here, and using this approach. I can also do the laminectomy in cervical spine using the similar approach. This is a 66-year-old male with esophageal cancer with radiation, so I decided just to perform laminectomy at 2 level. You can see the thecal sac traveling down there on the right side. And also lumbar decompression. This is an 85-year-old male with neurogenic claudication with 2-level severe stenosis. So this is what the tube looks like or cannula looks like with endoscope. I put this in to show that with endoscope you can actually achieve a better decompression contralaterally. This is the 3-4 level, and you can see the complete decompression of the contralateral side. And this is now 4-5 level. I'm dissecting my ipsilateral side. Patient went on the same day without any narcotics. So why do I do this? As I'm struggling through these surgeries, I tell my residents all the time, tubular surgery is great surgery. So, but if you look at the size of these incisions, when this lady with the 1-level posterior cervical foraminotomy came, I thought I performed wrong side surgery because she had a pimple or a mole on the other side. So you can see the size of the incisions, and this is the size of the incision for my 2-level lamies, and this is the 5-1 discectomy on a patient who had a L3-4 discectomy a few years back. So, but let's be honest, no one really cares about the size of the incision, right? Like I'm probably the only person who cares when I'm seeing the patients. They don't really care about their incision size in the back. So what happens underneath is more important. So this is a patient who had a prior laminectomy at L3-4 and L4-5 down here, and came in with level above severe stenosis right there. And I had a duotomy during the case, and so I repeated an MRI. Patient still went home the same day. Performed the laminectomy. I got the MRI, and this is what you see. You can see the well-decompressed nerve roots, and you can see the well-retained pseudomeningocele. And if you look at the muscle tissues, you can't really appreciate the scar tissues at all here, right? So another kind of fun case, 41-year-old with Harrington rod, left lower extremity radiculopathy. Here below the rod, he had a pretty severe central stenosis, and the hook was encroaching the midline. So I used a scope to kind of do the central decompression and also contralateral decompression at this level, and you can see well decompressed nerves there. So in summary, spinal endoscopy has replaced tubular retractors in my practice, plus more, right? Because you have transforaminal approach, and you can perform challenging approaches or surgeries such as thoracic disc herniations and L5, S1 bilateral discectomies. You can perform those with endoscopes without having to worry about iliac crest. All my surgeries with endoscope is now outpatient. I don't give any narcotics or opioids. Obviously, that comes with warning from the start. I really do think that tubular surgery is a great surgery, but I think there's definitely a benefit in performing endoscopic spine surgery because immediate post-op recovery is significantly different from what I've seen. I haven't had any wound issues so far or infections. It definitely comes with a high learning curve. Initially, when you start these surgeries, you will go from doing 20, 30-minute laminectomies to an hour, 20-minute, hour and 30-minute laminectomies. So my advice would be to start with more straightforward cases, such as L5, S1 herniated disc, which you don't really have to drill the bone at all. It's a very slick. You can introduce a scope right between the yellow ligament and get the fragment out. Transforaminal, when you're doing that approach, I would start with more of a foraminal and bilateral disc instead of trying more of the central disc because that tends to be more challenging. And utilize the courses. There is a lot of companies now, and they give out great courses and instructors and access to them. So if anyone has a question, that's my email and